Welcome back to Mayo Clinic Radio. I'm Dr. Tom Shives.
And I'm Tracy McRae.
Tracy, we have known for some time that there is an epidemic of obesity in this country, but it's predicted to get worse. If current trends continue, nearly half of U.S. adults will be obese 10 years from now, and 25% will be severely obese.
That does not sound good.
It isn't.
That severe obesity that you just mentioned, that's got some potential dire consequences. Severe obesity is associated with more disability, more disease, and more death. Today's guest is a nutrition and preventative medicine specialist at Mayo Clinic. We'll get his thoughts on the looming problem of severe obesity and also ask about trendy new diets, including fasting diets. Can they really add years to your life? Here's nutrition expert and the medical editor-in-chief of the Mayo Clinic Diet, Dr. Donald Hensrud. Welcome back to the program.
Happy to be here. Thank you.
Thanks, Dr. Hensrud. So we didn't think it could get any worse, but it's going to?
Those are the predictions, and this is a new study that came out that kind of looked at previous predictions and refined the methodology. So that's what they're saying.
And who's they?
It's a group that analyzed national data, and they used a little bit different methodology. We all tend to report our weight a little bit better than it is, so they accounted for that.
Believe it. Yeah.
And accounted for that in their predictions, and this is what they came up with. It's going to continue to increase.
Do you think they're accurate?
Time will tell. There was actually a study published some time ago that suggested the same thing. There's been a couple of them, but this is the more recent one. And if it is accurate, as you already pointed out, it does not bode well for the health of the country.
Isn't part of it that somewhere along the way the definitions changed a little bit as to what was obese and what was severely obese? Have those numbers changed at all?
The classification that they used did change. Severe obesity is commonly a BMI, and we'll talk about that, greater than 40. They used a BMI of 35. So there's a little bit different in the definition, but the definition of obesity, a BMI greater than 30, that remained the same.
All right, explain BMI to us.
Body mass index takes the height and weight and puts it into one number for classification purposes. We used to use ideal body weight as kind of a measure. BMI is a little bit better, but it's not perfect. It works good in populations, but in individuals it may not be accurate because it doesn't take into consideration body composition or muscle mass. So a bodybuilder may have a high BMI, yet have a low percent body fat and low health risks. But for the majority of people, it works pretty good in classifying health risks.
And it's pretty easy to figure out. You just go to the internet, put in BMI, you put in your height, and you put in your weight, and it'll tell you what your BMI is.
That's right.
All right, so give us the numbers. Where should we be? What's ideal?
A normal BMI is less than 25, from 18.5 to 25. One of the issues with BMI, it isn't intuitive like weight is in pounds. So 18.5 to 25 is normal. 25 to 30 is overweight, and greater than 30 is obese, and that's what we're talking about. They used a definition in their article of greater than 35 for severe obesity.
All right, the predictions also said that this is going to particularly affect women, this obesity problem. Women, non-Hispanic blacks, and low-income adults. Isn't that the way it's always been?
Yes, that's no change.
That's nothing new.
Right.
And worse in certain states, which I found interesting. Alabama, Arkansas, Mississippi, Oklahoma. Why is that?
It may be having to do with lifestyle, different diets. It's kind of the southeast of the country. An interesting fact, no surprise, that diabetes is more common in those states also.
And the lowest prevalence, I guess this doesn't surprise you because the people are probably more active, Hawaii, California, Colorado, and the District of Columbia.
Yeah, I don't know about the District of Columbia, but the others intuitively make sense.
You got to walk everywhere in the District of Columbia.
And it has been shown that in urban areas, people tend to weigh less for that very reason. They walk more.
Yeah, New York City, the same thing.
Yep.
What are the implications of severe obesity just versus regular obesity, for instance?
Some of the health risks increase dramatically in the severe obesity range, even overall mortality. So health risks generally start to rise a little bit in the overweight category, not too much. In the obese category, they rise more, but severe obesity is where they increase almost exponentially, the different complications, including overall mortality.
And what about the implications with regard to health care costs?
Oh, tremendous. We already know that we spend a tremendous amount of our healthcare budget on complications of obesity, and that's going to continue to skyrocket.
So the two big ones really for people who are overweight or obese, particularly diabetes and heart disease, right?
Yeah, although high blood pressure, obstructive sleep apnea, abnormal blood lipids, mainly high triglycerides, low HDL cholesterol, degenerative arthritis, gallbladder disease, the list goes on, complications from pregnancy or surgery. And so it really does affect a lot of things.
Why would you say that obesity is so difficult to prevent and so difficult to treat?
This is one of the biggest paradoxes that I know. It sounds so easy, just eat less and exercise more. And people, we tend to blame people for it too. But when something changes this dramatically in the majority of the population, there has to be powerful factors that are affecting this. And the best way to, I think, to look at this is it's a genetic predisposition that many of us have on top of a permissive environment where things have changed. We've engineered physical activity out of our lives in many different ways. One example, a simple example I use is we don't have to walk into the gas station to pay for our gas anymore. We just swipe at the pump.
You don't even have to walk up to the television to change its channel.
Exactly.
Or to open the garage door. Yeah.
And if you do that multiple times during the day, we're burning less calories both at work and in our lives. And our diet has changed too. We have a lot more processed food and other things.
So if those are the things that have changed, engineering physical movement out of our life, one of the things that people want to do is then fix the other factors like, well, then I shouldn't be so hungry, or I should want to eat more healthful things. Is there any direction in fixing those problems?
Oh, there are, and we have to look at this and attack this on multiple levels. We have to change the built environment and make physical activity the easier and the healthier option. We have to get the food companies involved and make healthier food that's lower in calories and make it taste good so people can buy it. But there are so many different factors that affect this. Another simple way I look at this is hundreds and thousands of years ago, the person who ate the most and did the least is the one who survived. Because in those days, everybody was doing activity and there wasn't a lot of food around. The environment has changed, but our inner brain still tells us there's a survival advantage to eating a lot and doing a little, taking the shortcut. So we, on an individual basis, we have to outsmart our limbic brain.
We were just talking, some friends and I were talking about the mental health aspects of your weight battle, being that if you're not feeling mentally fit, then you don't want to go exercise. You tend to not choose healthy foods, and that downward spiral contributes. And so the important thing being dealing with mental health issues, which sometimes people tend to step aside or push aside, really should be looked at.
You're absolutely right. And again, this is on multiple levels. Number one, we need to stop blaming people for their weight. It's not a choice that people make, and we're not we have some responsibility, but we're not as in control as what we think we are. Otherwise, this wouldn't be happening. And you're right about the vicious cycle. I see this in so many people, and it's hard to avoid. They may gain some weight, they're less energetic, do less activity, gain some more weight, and it becomes a vicious cycle. So we have to try and break those cycles. And over at our Healthy Living program, we try and do it with baby steps. We get people to adopt certain things they can do, build on their successes, and create a positive cycle.
How important is sleep in controlling your weight?
We definitely know there's a relationship, and this is one of these nuances. Calories in and calories out are still important by and large. But people who get less than 6 hours of sleep a night tend to weigh more for reasons we don't quite understand, whether it's hormonal or altered eating patterns. But that's a factor that modifies that energy balance equation.
You'd think they'd weigh less. I mean, if you don't sleep as much, you'd be more active, but not necessarily.
No.
All right, one last question. Where are we with regard to a diet pill? And I know there are some that you can order over the internet, and I recently saw a story that actually one of those can increase your risk of a certain type of cancer. Where are we? When is it going to be available?
In terms of over-the-counter products, I wouldn't waste your money. Okay. Not one has been shown to be effective long-term. We do have prescription medications, and they are used, and they can, under the right circumstances, lead to weight loss. One of the things that one of our investigators is working on here at Mayo is tailoring the medications to certain people. For example, some people have their stomach empties very quickly and they're hungry all the time. Well, if we can put them on a medication that delays that rapid emptying of the stomach, it might work more. And he has shown that this can almost double the amount of weight loss with medication. So again, individualization is very key in this whole area.
Do you prescribe to some patients prescription medications for weight loss?
My career path went more toward lifestyle some time ago. I used to do that, but there are practitioners here who specialize in that, and they know the ins and outs and can keep them on a program long term. I tend to focus more on lifestyle myself.
All right, Dr. Donald Hensrud. Well, if the predictions are correct, 50% of Americans will be obese and 25% will be severely obese by the year 2030. Now, the projections, well, they're sort of glum, but with some work and convincing people to make some lifestyle changes, which we'll talk about momentarily, we may be able to avoid what really seems inevitable.
It's time for a short break. When we come back, we'll ask Dr. Hensrud about trendy new fasting diets. Celebrities are doing that, evidently. We'll find out what diet he recommends and ask him about the new edition of the Mayo Clinic diet.
Welcome back to Mayo Clinic Radio. I'm Dr. Tom Shives.
And I'm Tracy McRae.
We are back with Mayo Clinic nutrition expert and the medical editor-in-chief of the Mayo Clinic Diet, Dr. Donald Hensrud. So, Dr. Donald Hensrud, we have talked about the obesity epidemic and how it's predicted to get worse. And now let's talk about some diets. And the first one we want to ask you about is fasting, because I saw a recent headline that said fasting diets may add years to your life as well as help you lose weight, a new study suggests. You agree?
Not entirely. The years to your life hasn't been proven yet. But where this came from, it wasn't a new study. It was a new review of the literature that was published in the New England Journal of Medicine in the end of December. And it reviewed all the evidence for intermittent fasting. And there are various ways of doing this. You can do it in one day, just limit your intake over a 6-hour period of time. You can do alternate day fasting, or what's been really popular in the UK is 5-2, where you're 2 days a week you fast. And there actually has been a lot of mostly short-term studies that have shown benefit from this in the body. For example, certain things happen when you fast. You produce more ketone bodies, and there are some beneficial metabolic adaptations that happen with fasting separate from just decreasing overall calories in a day.
Ketone bodies, they're good?
They can help decrease appetite. Keto is another diet, which is a little bit different than intermittent fasting, but there's a little overlap there.
Is it dangerous to go 2 days without eating anything?
It can be. And so some of the guidelines that they mentioned in this article were to ease into it. Initially, people often don't feel very good on, they may be a little ornery. I know I get ornery when I don't eat, and it'd be difficult for me to do, frankly. But as you get into it, they say after about a month of this and you ease into it, then you get used to it and some of the beneficial effects start coming out. But it can be dangerous if done in extreme circumstances.
It seems like there's some fairly credible evidence out there that fasting may be good for some people. The neuroscientist at Johns Hopkins, I'm sure you saw the article, Professor Mark Mattson, who said fasting may help your body improve its metabolism. It can trigger metabolic switching, whatever that means. Fasting is also linked with decreased blood pressure, cholesterol, resting heart rates. It can control blood sugar levels, increase resistance to stress, and suppress inflammation. All that true?
That was in that article in the New England Journal of Medicine. And short term it is, but we don't have the long-term data. One of the questions I have is, caloric restriction has been around for a long time. Animal models have shown that rodents tend to live longer if you feed them less calories. But if we as a population can't reduce our calories enough just to manage our weight in an effective manner, I think it may be more difficult for many people to try and even decrease calories more. And you can overdo it. I've seen malnutrition in people who have taken caloric restriction and fasting too far.
What is dry fasting?
So that's where people not only restrict calories, they restrict fluid too. Absolutely do not recommend it. There's no basis at all for that. You can get dehydrated and have severe consequences.
All right, let's talk about diets, and including the Mayo Clinic diet. The fact that there are so many diets out there would suggest to me that none of them really work all that well.
You're exactly right. The guidelines for treating obesity in this country, Dr. Mike Jensen was chair of a task force. He's from Mayo Clinic that came up with guidelines some years ago, and they came right out and said, there isn't one best diet. If there were, everybody would be following it. And this can be an opportunity. Some people might want to go toward a higher fat Mediterranean type diet that is lower in calories. Other people more a traditional Asian diet that's a higher carb, lower fat diet that's lower in calories. So there are many different options, and people can use this to pick one that works for them.
I'm going to go out and guess that you think the Mayo Clinic diet is the best diet of them all.
Well, I do have a bias in this, yes. And the reasons why are, number one, it's not only about losing weight, it's about health. If someone ate 500 calories from jelly beans, they'd lose weight, but that obviously isn't a healthy way to do it. So on the Mayo Clinic diet, we emphasize health-supporting foods. You can eat a lot of food, and it's based on the principle of calorie density, that if you eat a lot of fresh or frozen fruits and vegetables, that's a lot of bulk. You can achieve satiety at a lower calorie level.
Why did you have to put out a second edition of this? What have you learned that you needed to update?
What we did, people wanted certain things. They wanted more recipes. They wanted more menus. We put in a couple tables that have for entrees and for salads to give people ideas about what to eat. So in the salad table, you pick a protein, you pick a green, you pick a topping, a dressing, and people can mix and match and choose something that works for them.
I just have a question. I am fascinated. I'm not a vegetarian or a vegan or any, I just try to eat healthy. But why is it, do you think, people are opposed to plant-based diets? I feel like there's such an emotionally charged response to having a suggestion of, like, maybe you could follow a plant-based diet, and people really push back on it.
A couple of thoughts. One is that nutrition is a very personal issue. We all eat, and we all have our own taste preferences and biases about nutrition. Secondly, plant-based doesn't mean vegan or vegetarian. I think people have this in their mind that they can never eat things again. The Mayo Clinic diet is plant-based, but we don't exclude any foods. We just tell people to eat, or recommend to people to eat more plants, real food, fruits, vegetables, beans, nuts, whole grains, heart-healthy fats like olive oil. It can be a very enjoyable way to eat.
By the way, U.S. News recently ranked 35 diets based on input from a panel of experts. You might have been one of them. But anyway, number one diet, Mediterranean. The Mayo Clinic was in the top 5. But the Mayo Clinic diet is really quite similar to the Mediterranean diet, isn't it?
You know, we tend to label diets, Mediterranean diet, a vegetarian diet, Mayo Clinic diet, the DASH diet for high blood pressure. The similarities are much greater than the differences. They're based on real food and a lot of plants. And I think that kind of summarizes a good way to eat.
Well, the bottom line is the obesity epidemic is likely to get worse. There may be some benefit to fasting, but if you really want to lose weight and keep it off, it takes some lifestyle changes. Best diet? Mediterranean, Mayo Clinic, one of those top 5.
Whatever your
best,
choice
don't you think?
is, yeah.
Our thanks to nutrition and preventive medicine specialist Dr. Donald Hensrud. Thanks so much for being with us.
Really a pleasure.